Here we'll learn the pharmacotherapeutics of the movement disorder Parkinson's disease. To begin, let's write out the various forms of treatments for Parkinson's disease. First, dopamine replacement therapy, for which we use levodopa, L-DOPA. Indicate that it's used in conjunction with carbidopa, which provides peripheral dopa decarboxylation inhibition. As we'll see, carbidopa increases the circulating concentration of L-DOPA in the brain. Next, the dopamine agonists, mainly the non-ergot derivatives, ropinirole, pramipexole, and rotigotine, which is a transdermal patch. Indicate that these are actually more commonly used to treat restless leg syndrome than Parkinson's disease, and indicate the older line ergot derivatives, which are bromocriptine and pergolide. Bromocriptine is no longer used widely, and pergolide is specifically no longer available in the U.S. due to its association with valvular disease. Next are the COMT inhibitors, entacapone and tolcapone. We'll see that they play a key role in prevention of dopamine metabolism, meaning they maintain circulating levels of dopamine in the brain. Then the MAO-B inhibitors, rasagiline and selegiline, which also prevent dopamine metabolism, again increasing its circulating levels in the brain. Additional Parkinson's disease drugs include amantadine and apomorphine. Note that we leave out of our discussion that antidepressants, dementia meds, and GI meds that are used to treat this comprehensive disorder. Our focus here is on the movement component of the disorder. Let's begin with levodopa. Draw a body and label it the periphery, then draw a brain. Indicate that levodopa passes through the periphery to enter the brain. Show that an L-amino acid transporter regulates levodopa transport into the brain. Then indicate that via dopa decarboxylase, levodopa converts to dopamine. Specify that dopamine stimulates D2 receptors within the basal ganglia. So let's take a moment now to better understand the neuroscience of dopamine. Draw a brain and include the basal ganglia, which lie deep within the center of the brain and surround the cerebral ventricles. The basal ganglia, also referred to as the corpus striatum, notably comprise the caudate, putamen, and globus pallidus. Next, include the substantia nigra pars compacta in the midbrain, which is the source of dopaminergic neurons. Thus, we can imagine quite simply that the substantia nigra pars compacta produces dopamine and activates the basal ganglia. We know that Parkinson's disease involves a loss of dopaminergic neurons in the substantia nigra pars compacta and thus manifests most prominently with motor stiffness and impairment of movement. Next, let's consider the various dopamine receptors. Indicate that there are two main dopamine families, D1 and D2. D1 comprises receptors D1 and D5. D2 comprises receptors D2, D3, and D4. It's simplest to lump the receptors into their families, and it's often generalized that Parkinson's disease drugs act on D2 family receptors primarily. Now let's consider some of the effects of dopamine, which help us remember the side effects of the various Parkinson's disease drugs. First, psychosis, meaning delirium, hallucinations, and confusion. We can remember this if we remember that in schizophrenia there's excess dopamine. Next, show that with excess dopamine there are dyskinesias, meaning excess movement. Think about the excess movement in Huntington's chorea, for instance. Paradoxically, there are also akiniesias, freezing episodes, which is characteristic of late-stage treatment of Parkinson's disease, fluctuations in the fluidity of movement. Next, indicate that dopamine administration can cause cardiac arrhythmias. Then it can cause the hemodynamic effects of hypertension, or its opposite, orthostasis, which is hypotension. Now indicate that one of the most prominent symptoms is nausea and vomiting. Additional carbidopa is a helpful treatment for this, because carbidopa reduces the peripheral decarboxylation of levodopa, and thus reduces the circulating amount of dopamine in the gut. Finally, indicate the rare ocular manifestations of mydriasis and glaucoma, which can occur with dopamine administration. With that neuroscience as a background, let's return to our pharmacology. Consider the following features of levodopa. Indicate that it's rate of absorption is dependent on gastric pH and food amount in the stomach. Thus, it's commonly recommended that levodopa is taken greater than 30 minutes before a meal and with little or no protein. Indicate that without carbidopa, roughly 97% of levodopa is decarboxylated in the periphery. Thus, we'll see the importance of co-administration with carbidopa momentarily. Now let's review some of the key side effects of levodopa administration. Psychosis, dyskinesias and paradoxical akinesias, cardiac arrhythmias, hypertension and its opposite orthostasis, gastrointestinal upset, mydriasis, and glaucoma. Now we're ready to learn how carbidopa impacts the bioavailability of levodopa in the brain. Redraw the periphery and the brain. Again, show that levodopa passes through the periphery into the brain where it's decarboxylated to dopamine, but also show that it's decarboxylated in the periphery, preferentially so, to dopamine where it causes tremendous side effects, cardiac, vascular, GI, etc. Show that carbidopa works in the periphery to block this decarboxylation in order to increase the flow of levodopa into the brain. And show that carbidopa does not enter the brain itself. Thus, it does not prevent decarboxylation in the brain. As mentioned earlier, carbidopa can be added to Sinemet to prevent nausea. It's done so as the trade name Lodicin and can provide additional protection against peripheral decarboxylation of levodopa. Now let's address the dopamine agonists. Draw the periphery and the brain again. Here show that dopamine agonists pass directly into the brain where they act on dopamine receptors. Thus, they do not require a decarboxylation reaction. Indicate key side effects of dopamine agonists, which include most notably impulsivity. Gambling was one of the first behaviors to capture physicians' attention when patients ultimately reported incredible financial losses after being placed on dopamine agonists. But subtler forms of the disorder are quite common as well, such as an inability to resist a magazine at a grocery checkout. Hallucinations are especially common with this medication in Parkinson's disease. Sleepiness is another common side effect, and so is nausea and vomiting. Now let's address the COMT and MAO-B inhibitors. To do so, let's review some biochemistry of dopamine biosynthesis and metabolism. First, consider that the origin of dopamine is dopa, which we show now. If we remember that dopa refers to dihydroxyphenylalanine, we can remember that it comes from phenylalanine but with two hydroxyl groups. Phenylalanine has a central carbon with a carboxylic acid and an amino group. For the R group, attached at the beta carbon is a benzene ring, a hexagonal ring with 3 double bonds. Phenylalanine is the simplest of the aromatic amino acids. Show that the first hydroxyl comes from the formation of tyrosine. Redraw phenylalanine and add an alcohol group attached at position 4 on the benzene ring. Then show that the second hydroxyl comes in the formation of dopa. Indicate that dopa is a catechol because a phenyl ring with 2 adjacent hydroxyl groups is called a catechol. This will help us remember the metabolic breakdown of dopamine, which is as follows: dopa to dopamine to norepinephrine to epinephrine. Now show that dopa decarboxylase, the removal of a carboxyl group, converts dopa to dopamine. Indicate that it requires the cofactor pyridoxal phosphate, PLP, which is activated vitamin B6. Now we're ready to introduce the inactivation of dopamine via COMT, which is catechol O-methyltransferase, and MAO, monoamine oxidase. Show that dopamine metabolizes to DOPAC via MAO, and that it further metabolizes to homovinylic acid via COMT. Show that dopamine metabolizes to 3-MT via COMT, and that it further metabolizes to homovinylic acid via MAO. We underscore the tyramine and 3-MT, which stands for 3-methoxytyramine, because of the warning against high tyramine-containing foods in patients taking MAO inhibitors that inhibit the A receptor. indicate that at high doses, selegiline acts as both an MAO-A and MAO-B inhibitor. This is especially prominent in the transdermal formation. Indicate that important side effects of COMT inhibitors are the orange discoloration in the urine and that tolcapone can cause hepatotoxicity, which is why entacapone is used instead. For the MAO-B inhibitors, indicate that extreme caution has to be taken in what medications they can be used with. For instance, they cannot be used at all with any non-selective MAOIs. For instance, phenelzine, which is trade named Nardil, and they need to be used with caution with SSRIs and tricyclic antidepressants, and they can't be used with other serotonergic medications, cyclobenzaprine, dextromethorphan, meperidine, methadone, tramadol, because of the risk of serotonin syndrome. Lastly, it's common for selegiline to have more of an amphetamine-like effect than rasagiline, so rasagiline is typically preferred. Regarding amantadine, indicate that this drug was developed as an antiviral, but found to have particular benefits in the reduction of iatrogenic-induced, meaning medication-induced, dyskinesias, which are common in Parkinson's disease. Its major side effect is psychosis. Finally, indicate that apomorphine offers the opportunity for subcutaneous injection, which can be beneficial in hospitalized patients, especially with severe Parkinson's disease, who have no oral access to medication. But in actuality, it's rarely used because of the profound nausea it can induce. As you can imagine, all of the potential dopaminergic side effects are potentially much more dramatic with a rapid subcutaneous injection of apomorphine, which can be pre-treated with trimethylbenzamide. This concludes our diagram.